Welcome back to the deep dive. Today we're digging into something pretty huge, a major government effort, really. It's about how the FDA, the Food and Drug Administration, is completely redesigning how they watch over medical products after they're already out there for us to use. We're doing a deep dive into the blueprint for what they're calling the Sentinel 3.0 Data Hub and Scientific Support Services. Our mission really is to cut through all the government contract speak and get to the heart of what they're trying to build here. Because this isn't just, some IT update. It feels more like constructing this massive, very high-tech connected data system, the whole point. Keeping us safer by making sure the drugs, the biologics, the devices we use, they're all under constant active watch.
And the sheer scale of it really demands this kind of overhaul.
Yeah.
You have to understand. This entire system, it's actually fulfilling a mandate.
Yeah.
It comes from the Food and Drug Administration Amendments Act, FDAA, way back in 2007.
Ah, right. FDAA.
That's exactly. Section 905. It specifically required the FDA to build an active post-market risk identification and analysis system, ARIA for short. And Congress set the bar incredibly high. The system has to be able to tap into safety data covering at least 100 million people in the U.S.
Okay, let's unpack this. 100 million lives. Under active surveillance, that's what, nearly a third of the entire U.S. population? That's enormous. So before we get lost in the data itself, let's look at the structure. Because for years, right, different parts of the FDA handled their own thing. Drugs, devices, biologics, often kind of separately. How big a deal is this consolidation under Sentinel 3.0?
Oh, it's revolutionary. Honestly, it might be the single hardest part that isn't technical. You had CDR for drugs, CBR for biologics. Remember the BEST initiative? That was CBER. Right. And then CDRH for devices. Each had its own, let's say, regulatory culture, its own data standards, its own way of working. Sentinel 3.0 is essentially forcing them all into one single central collaborative framework. The idea is to look at all post-market safety signals through the same lens, whether it's, a pill or a pacemaker.
Merging three big, historically separate parts of a bureaucracy.
Yeah, that sounds like a massive undertaking in itself. And operationally, you mentioned it relies on three main pillars, and two of them are actually run by outside contractors.
Precisely. So at the top, leading the strategy, that's the internal FDA Sentinel Coordinating Center, or SCC. That's staffed by FDA people from CDER, CBER, and CDRH. They're setting the direction.
Okay, the internal lead.
Then Pillar 2, which is already under contract as of September 2024, is the Sentinel Program Management Organization, the PMO. Think of them as the project managers, handling the business side, the tracking, running the collaboration platform that sort of keeps everyone connected.
Got it. The operational glue. And the third pillar, this is what this new acquisition is all about, is the real engine room, the data hub and scientific support services. This is where the data actually lives and where the number crunching, the analysis happens.
So this new contract is basically to get the data, build the platform to hold it, and hire the brains to analyze it all.
Exactly. Securing those data sources, the tech platform itself, and the analytics experts needed to make sense of signals from potentially over 100 million patient records.
Okay, let's shift to the contract strategy itself. It sounds like the FDA isn't just hiring one company for everything, but you mentioned one vendor has a really big piece of this. It's a 5-year contract, right? Multiple awards.
That's right. It's a 5-year, multiple award IDIQ indefinite quantity contract. The plan is to award it by December 2025.
Yeah.
And that structure, multiple awards, it's very intentional for the data supply side, which covers tiers 1 through 6.
Why multiple awards there?
Because no single company out there controls all the different kinds of data they need to hit that 100 million patient mark. You need different specialists. The whole thing, with options, could run 5 years potentially until late 2030. But the key thing for you listening isn't really the specific dates, it's this. Any vendor who wins any part, any tier, they absolutely must cooperate with all the other winners. Their work is totally interconnected. You can't do tier 8 analysis without tier 7 platform and tier 1 into 6 data.
Right. Collaboration is baked in. Okay, so let's break down that data landscape. These tiers 1 through 6, what kind of data are we talking about?
So these are the data partners. Tiers 1 and 2 are focused on the big stuff. Commercial healthcare insurance claims data. Think of massive billing files.
The transactional data.
Exactly. And Tier 2 is interesting because the FDA specifically mentioned looking for third-party aggregators. People who can bundle huge volumes of claims data, and importantly, from both open systems like PPOs and closed systems like HMOs or integrated delivery networks. That gives them the sheer volume for that 100 million baseline.
But volume alone isn't the whole story, is it? You need more context.
Precisely. And that's where tiers 3 and 4 become, strategic game changers, I'd say.
Okay, so tier 3, That's healthcare insurance claims linked to electronic health records data, EHR. Why is linking those two so much more powerful than just the claims?
Great question. Claims data, like we said, it tells you what was billed. A drug dispensed, a doctor visit, a procedure code, it's the what. But linking that claim to the actual EHR data, that gives you the why and the how.
Ah,
Suddenly you see the diagnosis codes the doctor actually recorded, the lab results, maybe even physician notes, specific clinical details. For safety surveillance, figuring out if a bad outcome is linked to a product or just coincidence, that clinical detail is gold. It's invaluable.
okay, that makes sense. And Tier 4 gets even more specific. Specialty EHR data.
Exactly. Tier 4 is about drilling down into niche clinical areas. Data specifically from oncology practices or pediatric units, geriatrics, maybe intensive care units. These places track specialized information, specific metrics you just won't find in general claims or even standard EHRs. Tier 4 also includes things like patient registries and data from health information exchanges, HIEs, basically plugging data gaps. And then, to complete the picture, Tier 5 is CMS, data Medicare, and Medicaid.
Right. Crucial for the older population and lower income groups.
And Tier 6 is outpatient prescription data, so tracking what meds people are actually picking up gives you that full national view.
Correct. So those 6 tiers are the data supply. Now, Tier 7 and 8, they're the operational engine. Tier 8 is scientific support services. That's the analytics team, the brain power doing the studies.
Okay.
But maybe the single most critical piece, and maybe the riskiest strategically, is Tier 7, the data platform. This is the central vault and the tool set for everything. And you flagged this earlier, unlike Tiers 1 to 6, only one vendor gets awarded Tier 7, the data platform. That seems like a big bet. Why would the FDA take on the risk of, vendor lock-in by giving just one company control of the central environment for everyone?
Yeah, it's a classic trade-off, isn't it? Centralized control versus maybe more flexibility or less risk.
Yeah.
By picking just one vendor for the platform, the FDA is aiming for maximum interoperability, standardized security, simplified governance. Imagine trying to make data from 6 different competing companies flow smoothly across, say, 3 different competing platforms.
A nightmare.
The integration costs, the security headaches,
Yeah.
probably impossible. So they're clearly prioritizing tight, standardized control for that core infrastructure above almost everything else.
Okay, now here's where it gets really interesting. That single Tier 7 vendor, they have some massive technology requirements. Let's start with security. The platform must be a contractor-run multi-tenant cloud, and it needs FedRAMP moderate accreditation. And not just eventually, but ready to go by December 2025 when the contract starts.
Yeah, that timeline is aggressive. Brutally fast, frankly. Achieving FedRAMP moderate accreditation is a serious undertaking. It's not just a checklist. It involves rigorous assessment by independent third parties looking at over 300 specific security controls.
Wow.
It costs significant money and takes significant time. The fact that FDA is mandating this level, which is designed for systems handling sensitive, high-value government data, including PII, it really signals how seriously they're taking data protection this time around, maybe compared to earlier efforts.
Yeah.
It bumps this whole thing up into a certified high-security infrastructure category.
But the platform isn't just supposed to be a secure box, right? It needs to be smart. The FDA is explicitly saying this data platform has to integrate artificial intelligence, AI, and machine learning ML capabilities right into the workflow. How is AML actually supposed to find safety risks faster, better than humans or older systems? What's the practical application?
Well, the goal is really automation and speed. Current systems are often pretty reactive. They rely a lot on someone having a hypothesis and running manual queries. AI and ML promise a few key things here. First, just faster data wrangling, standardizing, and transforming data coming in from those 6 different source tiers. That alone is huge.
Streamlining the prep work.
Exactly. Second, automated signal detection and triage. AI might be able to spot subtle patterns across millions of records, patterns a human query might just miss, like maybe a complex interaction between a new drug and certain patient subgroups revealed only by analyzing unstructured text and EHR notes alongside lab values. It's really about using the tech to empower the human analysts, not replace them. Automate the grunt work, the initial screening, the data cleaning, so the experts can focus on the real signals.
And speaking of data, they also called out specific types of data they really want to get their hands on, things that maybe are gaps right now. What are those high priorities for Sentinel 3.0?
2 really jump out for the documents. First, getting access to data sources that can link healthcare data claims, EHRs to immunization information systems, or ISLIS across the country.
Ah, vaccine data linkage.
Critically important. That linkage is seen as essential for really robust vaccine safety monitoring, especially if there's another public health crisis involving mass vaccination. They need solid exposure data.
Makes sense. And the second one?
The second is an explicit push for medical device utilization data, and crucially, including the unique device identifier, the UDI.
The UDI, like a serial number for a device.
Kind of, yeah. It lets them track specific models or even specific lots of devices. Think pacemakers, hip implants, stents. Devices have often been harder to track systematically than drugs. Having UDI linked to outcomes across potentially 100 million patients, that's a massive leap forward for device safety surveillance.
That UDI piece really underscores moving from just general data to very specific item-level tracking. Okay, let's talk practical challenges. Data quality, data integration, especially when you've got, up to 6 different data vendors, plus the platform vendor, plus the analysis vendor.
Right, this is where the collaboration between Tier 7, the platform, and Tier 8, the scientists, becomes absolutely critical. The data partners in Tiers 1 through 6, they have the first responsibility for their data's quality and getting it ready. But the scientific support contractor, Tier 8, they act as a sort of final quality check and the main integrator. They're tasked with doing a second independent quality assessment on the summary data coming from the partners. And maybe most importantly, Tier 8 is responsible for putting the pieces together, integrating the analytical results if a study needs to pull data from multiple partners at the same time.
But integrating isn't just a technical problem, is it? You mentioned these data partners are often commercial competitors. They've got huge legal constraints, data use agreements, DUAs, high PA, privacy rules, the risk of accidentally re-identifying patients. How realistic is it to expect seamless cooperation when these companies have fundamental duties to protect their data, both for privacy and commercial reasons?
That is the central operational challenge, no doubt about it. The FedRAMP secure multi-tenant environment provides the technical walls, the separation, but the contracts themselves have to build the bridges. They need to legally and operationally enforce data sharing protocols, but only for FDA-approved studies. The RFI, the request for information, actually asked vendors point blank, how would you manage these legal limits? Things like restrictions on reusing data or what level of de-identification is needed. How can you operate legally in this shared platform while still protecting your company's assets and patient privacy? The whole success of 3.0 hinges on getting those contractual mechanisms right, ensuring competitors can and must play nicely in the sandbox for FDA work.
Okay, so let's walk through a scenario. The FDA Coordinating Center, the SEC, spots a potential safety issue, an emerging signal. How does the system kick into gear?
Well, it's designed to follow a pretty rigorous but hopefully faster path. The SEC gets the scientific question. The PMO, the program managers, they log it and track the study initiation. Then the SEC works quickly, collaborating directly with the scientific support team in Tier 8 and whichever data partners in Tiers 1 to 6 have the relevant data. Together, they hash out the study strategy, the formal protocol, and the statistical analysis plan, the SAP. The whole streamlined structure is supposed to cut down on that bureaucratic ping-pong you might have seen in the older, more siloed systems, aiming for speed.
And the vision here isn't just for the FDA's internal use, right? This platform could have broader impact.
Absolutely. That's a key part of the vision. The FDA clearly anticipates a much wider public health benefit. They envision other crucial government health organizations like the CDC, the Centers for Disease Control and Prevention, or NIH, the National Institutes of Health, also being able to leverage the Sentinel Data Hub, Tiers 1 through 7 anyway, for their own non-regulatory public health research. So it really could transform Sentinel 3.0 from just an FDA tool into more of a shared national health data infrastructure.
So let's recap the big picture here, the strategic impact of Sentinel 3.0. We're talking about a massive 5-year effort, likely costing billions, to build the single, unified, collaborative ecosystem. It's designed to link incredibly diverse data claims, EHR, specialty data, CMS, device IDs, all flowing into one secure cloud platform that meets that tough FedRAMP moderate standard and, importantly, infused with AI.
It represents arguably the largest, most ambitious integration of post-market surveillance capabilities ever attempted in the U.S., probably globally. The whole shift to Sentinel 3.0 is about transforming the FDA, moving from maybe a more reactive monitoring agency to a genuinely proactive, technology-forward guardian of public health. The goal is faster response times, more accurate identification of safety risks, potentially across 100 million American lives, by truly leveraging integrated data and these new AI capabilities. Which brings us to a really interesting question for you, the listener, to think about. Given just how sensitive this linked patient data is, pulling from potentially 6 different commercial and government sources, and the fact that the single Tier 7 data platform vendor must use AI and ML to make data more accessible and linkable, What innovative measures, things beyond just meeting the FedRAMP moderate security baseline, will actually be needed to satisfy the public's very reasonable expectation of privacy, especially if these AI algorithms start processing and potentially connecting data points that were always kept commercially and legally separate before. How do you balance that promise of speed and insight against the absolute need for data integrity, security, and maintaining those necessary separations? That's something for you to mull over.
A truly complex knot of technology, policy, and ethics. That definitely gives us something to think about. And that wraps up this deep dive into the FDA's ambitious new safety frontier. Thanks for joining us.